Thank you, Kevin. It's, as usual, a pleasure to be here. I know it's all about the right thing to do and not about money, so now for the next 20 minutes I'm going to talk about money. But what I want to do is talk about something that I thought was extremely important that happened earlier this year and that probably most of you never even heard about. And but before I do that, I'll tell a little story. The way back in ancient history, when President Barack Obama was junior senator, Barack Obama. He was in the Senate, and he got together with another junior senator that you may have heard of, Hillary Rodham Clinton, and they came together. They put together a bill which was called the Medic Act. What the Medic Act was, both of them were very interested in this issue of medical errors, and especially how to discourage them, and also the issue of full disclosure. So they put this together as a bill. The bill was intended, had it passed, to start to fund demonstration projects around the country, finding the best ways of doing this. They were aware of what we had done in the VA, and also what had been done at the University of Michigan. There weren't too many other places that were really publicly doing this at the time. Well, the bill failed, but they wrote this up as an editorial that was published in the New England Journal very prominently, and some of you may have read it. Well, fast forward a little bit, and now Barack Obama is president of the United States. He still is concerned about this, so what he did is, not being very successful in getting things through Congress, he simply went on his own and went and directed the Administrator of Health and Human Services to go ahead and come up with demonstration projects that would see which kind of a program would result in the most success. So in 2009, Secretary of U.S. Department of Health and Human Services was given this, and of course it flows downhill, so they turned it in turn to the Agency for Healthcare Research and Quality, AHRQ. And they were tasked with doing these studies and establishing a whole program that would be rolled out by AHRQ. And it was to meet these goals that you see there, putting patient safety first, preventing preventable errors, fostering better communication between doctors and patients, ensuring timely and fair and timely compensation for medical errors, and reducing liability premiums. So in June of 2010, the AHRQ announced a granting process. They had $23 million to give away, and they announced funding for 7 3-year demonstration grants and 13 one-year planning grants. What happened in May of this year was that this was completed. They came out, and on their website they put the results of all of these grants, all these projects, and also something else, which was a plan that was distilled from the successful grants that were led. The main areas that were covered by the demonstration projects were improving patient safety, improving communication, and exploring resolution methods, and they all sort of attempted to do this. The results, and all of these grants are abstracted on their website. The quality of these projects was quite variable, to say the least. And you could see that, having done this in the past and having been involved in grants like this, what happens when you say that we have so many millions of dollars to give away, this is the timeline. Some people say, wow, we need some of this money, and they throw something together slapdash and send it in, knowing that the agency has to give away this money. There are other organizations that perhaps have already been working on this and maybe have already finished what would be considered as one of these projects, and they put together something and sent it in. And you can sort of guess of who's going to be more successful at this. Well, one of the most successful ones was the University of Illinois Medical Center in Chicago that had been working on a project like this and put together something really good. And of the 7 demonstration projects, this was the only one that actually came out with statistical data that was significant. All of the others either lacked conclusions, had uneven adherence to the research plan, and some of these were sort of, if you want to just read some entertaining reading, some of these were almost ignored completely. Poor buy-in by participants, which is sort of deadly, and insufficient number of cases. So a lot of these grantees just weren't able to carry out what they had planned. This is one of the sort of ones that stood out by being not quite successful. They were awarded almost $300,000, and the plan was to use patient complaints to promote patient safety and reduce claims. They came up with 12 composites of patient safety and tried to link them to patient complaints. As it turns out, only 2 of the 12 were significant. The other 10 apparently didn't even show up in any significant way. However, they tried to spin it and make it positive, and they said, well, at least it establishes new ground for future studies within the patient safety movement. I suppose it does. And of course, the usual future studies would be necessary, which means they'll be in line to accept more money if it's offered. One of them was impressively positive, and if any of you saw the movie that my brother and I put together a couple of years ago, the one that was really very positive here was the one that was put together by several Harvard-affiliated hospitals, and they completely renovated the patient safety movement in Massachusetts, and this is currently in action in the Harvard-affiliated hospitals. It was they implemented a fully functional disclosure apology and offer movement in Massachusetts. I'm hoping that within the next year or two we're going to see some articles come out showing the results of this. The important part of this is they got all of the critical elements in place. Doctors affiliated with the Massachusetts Medical Society, lawyers from the Bar Association, the Academy of Trial Lawyers, plus their captive insurance company. Everybody was on the same page. Then they got laws passed in Massachusetts to make this actually possible. They put everything together. This started way before they accepted the grant. What they put together was called initially the Massachusetts Alliance for Communication and Resolution Following Medical Injury, or MACRME, which is a mouthful. They eventually renamed it Communication, Apology, and Resolution. And this is all, you can see all this on their website, which is www.macrame.info. It's a very nice website, and it shows what's going on right now, what the history is. I did check this yesterday, and yes, it has not been taken offline. It is still there. But anyway, eventually, after looking at all of these things, Macrame then they leased a contract to the American Hospital Association, which then put together the plan that was a toolkit that would be put together by that would be put online at the AHRQ. And this is the CANDOR Toolkit. This was the thing that was announced in May of this year. It is the entire package. If you are a hospital administrator and you want to put together a package like this kind of a program, all the tools you need are here. It includes slides, videos, and all the advice that you could possibly need, and it is absolutely free. In its most simple form, in block form, this is how it works. A CANDOR event is initiated. Basically, it's a medical error that has caused some harm. The system is triggered, and then 2 things happen in parallel. Both responding, telling the patient, giving information that is known at the point, at that point in time, including the fact that investigations are underway, and the investigations are also going underway, and then the thing just sort of revolves around. You give more and more information as you find out more, and eventually go to a resolution settlement. The process that is supported by AHRQ is very similar to the one that we did at the VA, that the University of Michigan does, the University of Illinois, Stanford, and a whole bunch of other hospitals. This has been tested in 14 hospitals within 3 hospital systems in the United States by the AHRQ. It includes background material, instructional tools, videos, techniques, and especially techniques of getting buy-ins by all the staff, and also training. As there is so much material on this spread around in the literature, it can be really sort of daunting to figure out what to do. If you're interested, if your hospital's interested in this kind of a thing, the AHRQ CANDOR process is a good place to start, where everything is there together and it's all free. And I might mention that you can hire contractors to come in and do this for you at a significant cost, but you can also do it yourself. This is just from the face page. It's a rather complicated website with lots of tabs and links to everything else. It's very similar to what we did in the VA. So why is it so complicated, and how hard was it in the VA when we did it? Well, we started this program back in the 1980s, and essentially we were able to do it in one day. It was very easy for us. We completely changed the entire culture in our hospital of how we did this, because it was an easily graspable problem. There was nobody over us. When I was the highest administrator there who really cared about this. Our lawyer was on board, and risk management was on board, and patient safety. And all we had to do was change what we were doing to start to do things in a way that was fairer to the patients. So it was fairly easy. Also in the federal government, there's no separate insurers. We had a captive staff. There was nobody else that we had to convince to do this. That is not the case in private hospitals, in university hospitals, and places where it's a lot more complicated, and you do have to have everybody on board. This is a top-down process. You can't expect lower-level staff to start disclosing errors, possibly to be even offering compensation, if you are not certain that your administrator is going to support you and back you up for this, because there is still a lot of inclination to fight these things in order to save money. So it was easy. It was relatively easy for us, but it is not necessarily an easy project for other people. I just wanted, this is the last thing I'm going to talk about, is just, and this has nothing to do with the CANDOR project, but it's an example of what can happen when people do this properly. This was something that happened in Honolulu, Hawaii. It was in the paper earlier this year. This was a gentleman walked into the emergency room with a sore throat. He'd had a sore throat for over a week, and he was looked at by the ER physician, who found a tonsillar abscess. He scheduled an appointment with an ENT surgeon. That was the appropriate thing to do. But while the fellow was in the emergency room, he said, well, why don't I take a look myself and see what I can do? So he sedated the gentleman and started to probe around in there. The fellow was a big guy, about 300 pounds, and was over-sedated, stopped breathing, lost his airway, and they could not get him intubated, and he died. So he walked into the emergency room with a sore throat and ended up dead. Now he was very fat. He had not sought medical care when this started. He'd been sick for well over a week. He'd put off going to the doctor. There were grounds for an aggressive defense, basically at least alleging shared blame in this. But the hospital didn't do that. Instead, they acknowledged what happened to the family. They worked together to try to change processes in the emergency room so that this wouldn't happen again. And they worked with the federal government to come up with a compensation package, which was a structured settlement of $4.2 million that would support the wife and the 3 children and provide for their education. When this was all in place, they had a press conference. There was a lot of hugging and appreciation up there among the family as well. Certainly this was a terrible thing, and this, you can't bring the patient back, but at least they did the right thing, and this was appreciated by the family. And it's that easy, and it resulted in, here's a fellow who died in the emergency room because of an act of malpractice, and the press report on it was a positive story based on how they responded to it. We had similar experiences when I was doing this in the VA. So it's an easy thing to do if provided that all the players are on your side. This is the AHRQ web address. It'll be in your hand. It's in your handout, or I should say, on your little flash drive. I recommend taking a look at it, possibly talking to people in your hospital if you think they would be receptive. But it's really a wonderful thing, and unfortunately, it didn't get very much press coverage. Thank you very much.